Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it.
Hi everyone, this is a special episode of Cold Steel we recorded on COVID and the impact it's had on surgeons across the country. We were lucky enough to be joined by two trauma surgeons and intensivists who are actually repeat guests on the show. Dr. Morad Hameed is a trauma surgeon and intensivist at the Vancouver General Hospital, and Dr. Parry is a trauma surgeon and intensivist at the London Health Sciences Centre in London, Ontario. We went over how surgeons have been adapting to the COVID crisis and some basics of COVID management. We hope that you find this useful, and we hope that you all stay safe.
Drs. Hameed and Parry, thank you again for joining us on such short notice. It's exciting in the fact that you're the first repeat guest we've had on Cold Steel. However, certainly the circumstances are tough. We thought you two in particular were in a perfect position given your critical care practice and your hospital leadership positions and also functioning as trauma surgeons to talk a little bit about how your hospitals and your healthcare systems are dealing with COVID, maybe how your colleagues are dealing with COVID, and then I think we'll get into some of the nuts and bolts of both the epidemiology as well as maybe some short cursory comments on ventilator management. So welcome and thank you.
Thank you. Thank you, Chad.
I guess let's start off really broad then and just ask you guys, how have things changed at your hospital? Have you canceled elective surgeries? How are you dealing with all of these issues at this crazy time? And maybe Morad, we can start with you.
Yeah, we've had a pretty big transformation in the way we've been approaching patient care. I could never have imagined that a viral pneumonitis would disrupt the entire operations of an organization so profoundly. But everything seems to be changed, and general surgery and trauma have had a big role in that transformation. So, you're right, Chad. We, in order to create capacity, we instantly stopped doing elective surgery. So our OR activity reduced substantially, probably to about 40% of its baseline activity. And that actually gave us a little bit of breathing room to not only discharge patients and drop our censuses, but also to readjust our own call coverage to create a bit of surge capacity within our attending call schedule, and also to realign our residents. We got all of our residents back from their community-based rotations and rotations around the province to the main COVID site in the city. So the decreased activity gave us a little bit of capacity to react and then to create some surge capacity. But that's taken many hours of meetings and phone calls and text messages.
And so, Chad, or Morad, how many ORs are you guys running a day from what you would normally do? If you can give me at VGH.
So normally we run we have two sites, Vancouver General Hospital and UBC, and VGH runs about 19 rooms every day, and that's gone down to about 5 to 6 rooms a day. But that changes almost from day to day, and we've been warned that OR allocation to services could change just on a moment's notice. Right now, general surgery has 3 rooms a week in our main Vancouver General Hospital OR, and then 3 rooms a week at UBC, which is more of our ambulatory hospital. So we still have slowed down limited access to slates, but we can get scheduled surgery in. How about you guys?
Yeah, so I think all the things you mentioned initially has been the same in London. The landscape is like everybody, it's completely upside down and changed. And we about 2 weeks ago went down to running at about 40%. So from 17, 18 ORs at the Victoria Hospital and about 15 ORs at University Hospital, we all went down to about 40%. And then just this coming Monday, we're going down to about a quarter. So we're probably going to run 4 rooms at each site. And then our more outpatient hospital will probably run about 2 or 3 rooms. So 2 emerge rooms and then some scheduled urgent, limb-threatening cancer type surgery. So it's been, it's been a massive change, clearly.
Has this reduction been in response to a surge of new cases, or are you still sort of anticipating?
Yeah, no, it's more the latter. So it's interesting, and I think it's probably going to be similar across the country. How, one initially may think that, wow, COVID, what's the role for surgery with COVID and this huge pandemic? But I think it's huge. One, obviously, from what we have to deliver on an everyday basis, things are still going to occur, so we have to be very mindful of that. But just from the leadership point of view, I can say that I think, again, I can't be too subjective about this or objective about it. But I can say that in our system, I think the surgery leadership has been very good, and quite honestly, has been several days ahead of the hospital administration in decision making. So even for us cutting back our ORs, we brought that to them. And so when it's a group of surgeons that say, listen, we need to do this because it's the right thing to do to prepare for such a pandemic, that's a big statement. And I don't think really the hospital would initially realize what a big statement that was.
I love that idea. That I think when surgeons devise their own solutions and come forward with them, I think that works so well. People are waiting to hear what we say and how we respond. And one interesting thing I think that's coming with this is that as general surgeons and trauma surgeons in particular, I think we're used to working in times of crisis, and so we're used to making decisions under conditions of uncertainty, and then refining those decisions as new information comes in. I think that mindset kind of helps in this situation.
Absolutely.
And even in the concept of triaging severity of patients. So, like, in our division, we pooled all of our cases, all of our scheduled cancer cases, for example, to try to figure out within our group, how do we triage them when OR time does come available. I know, Chad, you've thought a lot about this because of doing such a high volume of cancer surgery.
Yeah, it's hard. It's as we've talked about, it's hard to communicate with those patients that are at home with cancers that may or may not leave the resectability window in some of our more aggressive tumors. Those are hard conversations, and they're hard on the individual level, and they're hard on the system, and it certainly creates moments and days of frustration for sure. And mostly for the patients, of course. I can only imagine what they're going through. But you're right; it's got to be done at some level.
And I think that. Mm-hmm. So go ahead, Jed.
I was going to say the corollary for all three of us, of course, our other love is trauma and injury care, and I'm curious how that's going in both London and Vancouver. And the reason I ask is I just had come off of our trauma service here in Calgary on this past Friday morning, and it was probably the busiest week I've had here in over a decade. It represented really an inner city American center. I mean, there was half a dozen gunshots every day. There was more than that in stab wounds. There was tons of injured people, and I don't know whether that was from just a sort of it's a pandemic, let's get crazy point of view, quite honestly, or whether it's because the social services that these marginalized on the fringe type patients that we see have had to pull back as well, and they're sort of left on their own. I don't know, but it's certainly something palpable and real had changed.
Yeah, I just want one comment just back to the cancer side. I think it has been exceedingly difficult, and I think sometimes the the public may not understand, but I think it should be very clear that the physicians and the surgeons are still doing their best to advocate for this. Yes, unfortunately, given the circumstances, surgery time will be delayed, but it's not without the surgeons really advocating hard for this and trying to make time out of nothing. It's very, very difficult.
Yeah, Neil, I agree. I think as surgeons, we probably have to take a longer view than our emergency operations command centers, because they're very focused on the immediate goal of creating capacity for COVID-19 patients. But I think what we also know is that once the pandemic passes, when it will pass, we'll have this big rebound of cases that need to be done.
How are we going to find the capacity for this, right? There's all sorts of different things to think of.
Exactly. And so I think that means that while we prepare for the current crisis, we also have to have an eye on the horizon to say, what's it look like? How are we going to handle that rebound and care for the population the best we can? When we do start to get access to the OR, how will we prioritize our patients, bring them in, be efficient, that kind of thing.
Yeah, and as you mentioned, it had to be very dynamic too with the OR. It can change from day to day, from week to week, as far as yes, okay, today it looks, things are fairly under control, blah blah blah. We may be able to get a few more cases, and we'll see how it goes up, and same goes the other way, unfortunately, also.
Yeah, and that has to come from us. I don't think that can come from a hospital administrator who doesn't necessarily know what we do.
Yeah.
One of the things that obviously the group of us on this call have the privilege of doing is dealing with emergency general surgery cases, trauma cases, and cancer cases. Those are obviously, by definition, three of the most urgent categories that we all deal with. But how to speak to other types of surgeons, and I'm sure there's orthopedic surgeons and plastic surgeons and gynae surgeons listening to this as well. How have you guys found those folks that have been, maybe don't do trauma orthopedics or don't do emergency gynae work? How have they been dealing with it at your hospital? Because that's a really tough position too.
I think all in all, the division chiefs that I've spoken with have been outstanding, to be honest. The arthroplasty group, that would operate 24/7 if they could, have said, listen, we can't do this right now. And they've stopped. And it's incredible. I think that speaks just for, we understand the magnitude of that statement, but I don't think really anybody else who's not a surgeon that really can understand that. But they've all come forward with this as well.
One thing I've kind of felt like watching all of this is that, our personalities as surgeons isn't the type that can just sit on the bench, right? Like, I don't think any of us growing up playing on sports ever were content being those people on the bench. But yet, I think part of our leadership, as you have all of you have said, is actually being able to say, this one, our role maybe right now is just to sit on the bench. And that's very hard, I think, as surgeons to do. And I think that shows a lot of leadership that everyone across the country has been able to do that.
Let's transition into a little bit of specifics about COVID, if it's okay with you guys. Morad, are you treating your trauma and emergency general surgery patients like they may have COVID across the board, or how are you nuancing that?
This has been a really big journey, Chad. When it first came down the pipeline, information about COVID was suggesting that we screen patients that are symptomatic or have some type of travel history or infectious contact. And that's fine, but then it sort of came to light that there's a median 5.1 day incubation period when patients do have a fairly high viral load but are not yet symptomatic. So there's this long pre-symptomatic phase. And I think that pre-symptomatic phase is one of the reasons why the pandemic has been so hard to control. People are infecting each other without knowing that they have symptoms. So I think I saw one model where they thought that about 12% of transmissions were from pre-symptomatic or asymptomatic individuals. So, and I know that in nursing homes and in other healthcare facilities, That's one of the reasons why the disease can spread like wildfire. It's because people limited their screening to symptomatic individuals. So we've taken the position, at least for now, that we're assuming that general surgery and trauma patients have COVID positive until proven otherwise. And we're advocating for PCR testing now. PCR testing has been hard to get sometimes, and the turnaround times are getting better, but what had not been perfect. And we've also learned that PCR testing is not 100% sensitive. In fact, we know that it's about like 70% sensitive in some theories. So then what we try to do to try to mitigate that sensitivity is combine it with a CT scan of the chest. And we've seen that the pneumonitis can sometimes appear on CT before the PCR turns positive. So that's been our strategy. Guys, like I'd love to hear what you do, but the idea is to advocate for PCR testing everybody that's going to the OR, and if they haven't had a CT test, try to get the CT test as well, and that gives us some confidence about whether someone got the pneumonitis or not.
Yeah, it's an interesting comment. We have a post-Whipple patient on our service now who developed the clinical concern for COVID. The chest X-ray and subsequent CT scan is classic, straight out of the Lancet. And the test was negative. The initial test was negative. Subsequently, it's been positive. So that's a real-world concern for sure.
Wow.
Have you guys heard of any teams getting infected yet? I heard that there's a team at Columbia, a transplant team that got exposed, and some people got transmitted, but I haven't confirmed that.
I heard that as well, but haven't heard of any in Canada yet from surgeons.
Yeah, so far so good, I think.
We do a similar thing with regards to our acute care or emergency general surgery patients. They're all treated as if they're potential or positive, whether they pass or fail their screen. And Emil, I guess, will probably lead into this as to what we do up in the operating room. So, if they're on the ward and they're coming up to the OR, we're not doing any aerosol generating medical procedures, then we can all wear our enhanced droplet precautions. And this would be interesting to find out what you guys do as well in your ORs. We've gone from the gamut, as Morad was saying initially. We would, before we really knew about the big lag time that they can have while they're asymptomatic, we would treat our patients that screen negative. We would, in the OR, we would just do our enhanced droplet precautions. And now we've switched to our enhanced aerosol precautions. So N95 is the equivalent for everybody. So any OR that we're running now, we'll do a little huddle ahead of time with the anesthesia, nursing, surgery, OR aides, RTs if necessary, up front. Everybody should delineate the roles, see who's going to be in the OR, limit personnel, limit people getting in and out of the OR, and then proceed on with surgery with everybody with their N95s. We try to intubate the patient in our rooms. We just anesthesia and minimal personnel. Usually surgery waits outside, then comes in after talking with our microbiology, infectious disease and facilities. After 10 minutes, then come into the OR, proceed on. We're still treating surgery as possibly aerosol generating, so that's why everybody in the room is wearing their N95s. We do not have any negative pressure ORs, and what we've been told, and this I'd like to get your opinions on this as well, but we've been told from our local experts with the positive pressure ORs that we use, where the air cycles between 20 to up to 30 times within the hour, that it's actually, given that this is mainly a droplet precaution type disease, although with the AGMPs it can obviously be aerosolized, it's sufficient enough. I don't know what your thoughts or what you guys do in your ORs.
Yeah, that's exactly right. I'm so happy to hear that, how you're approaching it. I think that for all of us, the safety of our teams, and particularly our residents, is something that keeps us up at night. And so just erring on the side of enhanced airborne precautions for potential aerosol generating procedures I think it's a great principle for now, and we follow pretty much exactly what you said. Limited. So there's a kind of a two-tier approach. I think first of all, kind of incorporating social distancing, clinical distancing. In our case, it's keeping surgeons and residents out of the hospital as much as possible, cycling them in when needed, reducing the size of our teams that are assessing patients, and reducing the size of our teams that are coming into the operating room. So that's the social distancing side. And then on the personal protective equipment side, yeah, absolutely. We do the same thing as you guys. We strive to do that. We did get a little bit of question about, like, is laparoscopy aerosol generating, and is placing chest tubes or doing a laparotomy aerosol generating?
Yeah.
I'd love to know your position on that. My position is that we should assume it is until we have data proving otherwise.
Yeah, I think we've gone along that road as well. I think, again, I mean, our local experts in microbiology and infectious disease are fantastic. Again, I'm not sure, but they totally understand the OR culture scenario, the break, what we exactly do all the time. And it can easily go from one non-aerosol generating medical procedure to being aerosol generating in certain circumstances, like a chest tube and that type of thing. So we would do the same thing. I think the issue with laparoscopy also is, not me, but the current generation of residents that are just coming out are, they've done everything laparoscopically.
Yeah.
If they can do it as quickly, then I think here time is really of the essence, because our access to the OR is severely limited now. So if you're going to take a long time to do a subtotal colectomy and you want to do it laparoscopically, rather than doing it open, where you could potentially, certainly at least in my hands, I could do it faster open, but it all depends, right? So I think that's another aspect to think about with laparoscopy and this smoke generating thing.
Well, let me take that one step further, Neil. Open versus laparoscopic for some procedures, as you point out, is a real world question right now in the here and now. But the American College sort of dropped a recommendation and then backed out of it shortly. Talking about essentially indications. So treating patients with appendicitis with antibiotics only, same thing with cholecystitis. What are you guys doing at your institutions? Have you changed your indications at all? Are you going to the old days of doing that?
No. I think that if you can get someone in and out of hospital within 24 hours, that's the way it should be. Rather than sticking a drain in something, having people come and check the drain, there goes your social isolation that needs to be done. Having someone on IV antibiotics, you need a nurse to come in. Yeah, I'm sure we could get into the behind scenes of all of this, but the fact that they came out with the change so quickly, I think it's safe to say people were in uproar about it.
What about you guys in Vancouver?
That was a big 180. One of our residents, Corinne Susan, sent me the first version, and I was pretty surprised. And then within a day, sent me the second version. And I feel like maybe the ACS was trying to anticipate the worst case scenario where we have no access to the operating room.
I think you're right.
And then I think the reality is that most places do have somewhat limited access and can triage cases in there. And so I think they came up with more of a nuanced document to say, yes, you can do MIS procedures, and you can do choles and apneas, and in addition to perf biscuits, and you can even do procedures that, if you do them, you can keep patients out of hospital better. So crescental biliary colic suddenly appears on that list. So I think the second document is probably more common sense, and probably reflects the reality that we do have some access to the OR. And Chad, and to your point earlier about some services having, and Amir mentioned that some services are now kind of going on the bench, and patiently waiting for the pandemic to subside. With trauma and general surgery, I found that our access has been preserved. So I think that's an acknowledgement of the fact that we do a lot of emergency stuff. And so hopefully, as long as that access is preserved, we can get some of these patients through.
Preserved, but still decreased overall.
Preserved, yes. Yeah.
I think one of the big challenges that it's been hard to deal with for everyone is that we're having to deal with very limited information. and have to make really big decisions like, shutting down the elective ORs when we don't really know how long or how hard this is going to go for. And then, this laparoscopy is a good example. Treating appendicitis and cholecystitis with antibiotics is another good example where, for better or worse, we have to make these decisions with very limited information. And it's even on an even broader front, like you can see the things that are getting published in the New England Journal, etc., with very small patient populations, very small RCTs are finding their ways into very big journals. And so I'm curious how, all of three of you are academic kind of heavyweights as well as in administration. How are you guys dealing with, the lack of information, but still having to make decisions to protect healthcare workers and the general public?
Well, I think that's a good question, Amir. Part of it, is reflected on what Morad said, and I think it's also part of how we're trained as general surgeons, and I think it's how you're being trained as a general surgeon. Almost as conclusion now, you're trained to think in an adaptive way, in less than optimal or essentially suboptimal conditions. And I think that's not just how do you do a tough trauma operation when things are going sideways and the patient's trying to bleed. I think that applies to this sort of scenario as well. You're essentially a high-level problem solver day to day. It's just the problems look different from day to day, and this is a classic example of that.
And you're right. Like I just feel like it's a tidal wave of studies and anecdotal information and podcasts and like WhatsApp chats, and you're trying to process all this information. But the one thing that you can cling to, the life raft that we have, is a lot of this is very just basic common sense decision making, and even how you organize your system. We know how to do that from our experience with developing surgical systems and developing trauma systems. But even at the bedside, sifting through all the data, it can maybe refine 5% of your management, but the other 95% is what we've known to do all along, with going back to the ABCs and basic lung protective ventilation and protecting our staff. So it's a lot like other things in surgery. The first principles really are most of the biggest part of the approach.
Yeah, no, it's great. I couldn't have said any better than that. I would just say, we all try to work with best evidence possible. We try to change our practice that way. We're now in the realm of Twitter-based medicine. It's not really all evidence-based, is it? The amount of information we get is staggering. And this gets changed to that. I don't know how much is the telephone game. This gets published in these, as you mentioned, here's an RCT of 6, and it's published in some journal. I don't know what to make of that. And if we step back, I would never change my practice based on that. But people are doing that now. And so I think we have to be very mindful of that. Again, just take a step back to say, really? How about that, HM? I think that's what we still need to do. And again, it's evolving because of we don't really know how this bug works in a lot of senses. So it will evolve, but we have to have a look at it still and have a critical eye with things.
Yeah, it's going to be interesting a year from now to look back at all this and see what was accurate and what was inaccurate. No doubt.
Mm-hmm.
If I switch up the gears a little bit on you guys and just point out to our listeners, Amir is in his final year of residency and was supposed to do the Royal College exam this May and June, and then of course you, Neil, are on that board, and then Morad as a previous program director and as a section head in UBC. I'd say that first of all, it's incredibly stressful for our 5th years, and just wonder if you guys had any comments on that or any thoughts moving forward.
I'd like to hear Amir's thoughts on it personally.
Yeah,
just to see how you, Amir, and your cohort, but I know you guys are in touch with everybody across the country from PGY1 to whatever. What's the sort of what are people thinking? What's the morale like?
Well, it obviously was very hard to get that news because I think everyone was sort of hitting their peak. In fact, I think next week was our last week that we were really going to be clinically busy, and then after that it was dedicated clinic or study block time. So this was very, very hard for Royal College residents or final year residents across the country, not just in general surgery, but in emergency and anesthesia, anybody who had to take their final exams. I think there's all of us are 100% dedicated to being on the front lines and being there to help out. And I think we all recognize that we bring a lot to the table. I don't think anybody knows how to get stuff done in the hospital better than I do. I know exactly who to talk to or who's the best at doing what. And I think that we bring a lot of value to the whole system. I think the frustrating part was we wanted to do that, but there's so much uncertainty. And, there was a bit of back and forth as to, it seemed like it was postponed, then it was going to be back on, then it was postponed again. And so that, I think, added to the frustration a bit. I think most of us are kind of resigned at this point to just roll with it. I think probably most of us felt that, this might have been the time to try some new things, like try a written exam or online or try some other new things given the circumstances. But I think the bottom line is that all of us are a bit resigned to it now, and we're focused on how can we best prepare and best help out the hospital and our colleagues in this time period. And I've talked to a few residents from across the country, and I think we're all kind of on that page.
That's a great point, Samir. I know that it is devastating to have this happen. I'm sure there are opportunities in it, though. And I know that everything's going to work out great for your class. But that's a really interesting point you raised about the Royal College. I mean, I think they're still doing paper-based written exam.
Yep.
And this would be the year. Out of this crisis would be the opportunity to really move into the 21st century with the way that exam is delivered.
Yeah, they're so close to doing that, just not close enough. And that's the really tough part for this cohort of fifth years, because that is completely in the plan, but it's been a little slow, and it's a real shame.
But let's use that concept maybe as a transition into another macro topic, maybe to discuss, which is that clearly, at least I hope, the world's going to change, really in all aspects. Some hopefully for the good, and I'm sure some for the bad, whether it's the economy or so on. Everyone's struggling. There's no doubt. But how do you guys see, on the positive side, this pandemic crisis potentially changing the way that we do business or do care or look after people or interact, again, at a macro level in our healthcare systems going forward, if we look a year or two or three out?
I think, Chad, from my perspective, I think this crisis has really made us aware of two things. It's made us aware of the constraints of our healthcare system, and the real need to make this a value-based system that's very aware of both quality and cost. But it's also made us very aware of our synergy, and it's been, like Neil alluded to this earlier, and Amir, but it's been a pleasure to work with across disciplines to solve problems. I don't know, I have never seen our faculty and residents across all specialties so engaged and so involved in trying to work out solutions to things together. And even within our own division of general surgery, which sometimes has its own subspecialty agendas, people have really come together to try to figure out what's best for patient care. And across the province, I've noticed that there's incredible communication between hospitals, and we have a big province and many hospitals, and we have an online platform where everybody is contributing online, communicating, exchanging ideas. And so yes, it is a crisis, and we know that our healthcare system is in perpetual crisis, and this has really brought some of those into sharper focus with some of the shortfalls into sharper focus. But they've also shown that we can get together and solve problems and share ideas and scale good ideas really well because we have the technology. And we didn't mention this, but I'd love to know what you guys are doing. But we've started to use Zoom for all of our meetings and rounds, and we're doing our morning report via Zoom. And it's paradoxically increased the engagement and communication. It's just using virtual meetings and virtual care has almost in some ways given us new opportunities to communicate.
Yeah, there's no doubt. Like I guess we all should have bought Zoom stock before this crisis. But we just, for as one minute example, we just conducted our HPB fellowship interviews. We had 12 candidates. We did them all by Zoom. It was half a day, and it was a remarkably interesting experience. It was the mechanics were different. The interview was different. The time frame of the interview was different. I wouldn't say good or bad, just truly different. And I think will certainly inform different options and different ways of doing things, even on that small level moving forward.
Yeah, I think that is there's so many things. It's hard right now to look at this as a glass half full type issue, but I think what Morad has mentioned also about the relationships, we can make things happen. I personally have learned so much from other people during all of this and how to do things and to do things better. And this remote access for not only that, but for our patient care. Mm-hmm. Do we need to, have somebody drive 200 kilometers? It doesn't make any sense just to say, hey, how you doing? Look at this. Look at your wound. We can do things. If there's an issue, clearly different, but there's so much that can change from that.
And suddenly in 1 week, the healthcare system transitions to seeing those patients 200 kilometers away.
Yeah, and we can. So as you said before, even just on the academic side, that the use of the remote access has improved the uptake. Well, this may improve access, like actual access to medicine, to surgery, by having these remote things for the remote communities. Maybe we'll buy back into this again, where it's been a lot of talk about remote telehealth and whatnot. And yes, it is being utilized, but still nothing close to its potential.
Well, that's just it. Andy Kirkpatrick and I talked on Cold Steel about exactly that, and we both felt a little bit guilty about not driving that to a greater extent, especially when you see the Australians leading the way, and you have, the trauma surgeon in Brisbane helping remote guide them under real-time video guidance up in Darwin, for example, to do a whole bunch of things, including just big run-of-the-mill trauma resuscitations from crashes. And we in Calgary, we tried to do that we did do that for a while between the Foothills and Banff, and that sort of fell away when the technology wasn't quite perfect, and there was no billing code to be able to do that in Alberta, and there still really isn't. Some provinces have it, some it doesn't, but there was enough issues there where it sort of faded away. But the opportunity, the reinvigoration of that chase should happen now for sure.
Yeah, and you bring up one word there, billing, and I don't want to get into all of that now, but now that it's hit North America, where physicians are more so on a fee for service type of billing, whereas certainly in Europe and further east it's more salary based. This will create a whole new complexity to this crisis.
Yeah, no doubt. Well, Canada specifically, right? The vast majority of U.S. physicians are still salaried, but it's an interesting time for Canadians as well. No doubt. Well, let's transition maybe into some nuts and bolts of COVID specifically. So, using the critical care backgrounds, guys, what are your recommendations in terms of, besides assuming our emergency patients all have it, and precautions and PPD and so on, what are your comments about basic management, whether that's, antimicrobial, steroids, hydrochloroquine, ventilator thoughts, and so on?
So I would just say, from seeing the patients, I haven't seen any. I had to look after any COVID positive patients yet in the ICU. I'll be there a couple of weeks and will. But it's the basic tenements that we would with. This is hypoxia that they have, so it's not a ventilatory issue. Initially, these patients will come in quite profoundly hypoxic, but yet their lungs are still quite pliable. They're not stiff yet. So it's all about oxygenation, ensuring they've got adequate ventilation as they are, keeping them as comfortable as possible, and depending on what mode of support that we want to use for that. There's been a lot of talk about high flow nasal cannula or BiPAP, CPAP, pros, cons. Be interesting to know what you guys are doing with either of those. We are using the high flow nasal oxygen if they can be isolated and if they can be in negative pressure rooms. And we're actually proning those people. The physiology of proning makes sense. We do it with bad ARDS, but why not do it when they're still breathing spontaneously? And it works. Their oxygenation improves. Currently right now, our infectious disease, given that, we don't have a lot of cases right now, so 3 in our ICU, they have been managing thus far with basically a protocolized approach to any type of medication for it. And really, certainly from what I read, there's not a whole lot that really works apart from supportive care.
What about a Zithro or chloroquine?
Not to talk about it. I don't know. Honestly, it's not certain. I don't know. I defer that to our ID group. They have instituted that in a couple of other retrovirals in their algorithm, but I'm not going to debate them about it.
I couldn't agree with you more. I think that's a very great common sense overview of management of this, and it's been fun reading about it. Like I know that the way they look at this COVID-19, the pathogenesis of it is that there's an initial viral stage where the virus attacks the type 2 immunocytes at the ACE2 receptors and causes a direct viral-induced lung damage. And so patients start off with upper respiratory and then progress to lower respiratory symptoms. And they are shedding virus during that time. And then after a while, there's a sort of a hyper-inflammatory state when the body's adaptive immune system kicks in and starts fighting off the virus. And then so you get a secondary type of delayed illness that's more of a ARDS, multi-organ failure type of pattern. And so patients can look like they're getting better, but then suddenly go into really renewed respiratory failure and multi-organ failure. So that's interesting because, like you mentioned, at the beginning when patients are in the viral phase of this illness, there's no real specific antiviral therapy for it. So the idea is to treat them initially prophylactically for community-acquired pneumonia, support their respiratory status, use high-flow nasal cannula. When we first saw these patients, when we were first receiving them, we were worried that they would be very difficult to oxygenate and recruit. But just like you said, that once they're intubated, the lungs are not that stiff. You can actually recruit them with a bit of PEEP, and you can oxygenate them. And then initially we were nervous that we shouldn't wake them up too early because of the risk of the secondary inflammatory response. But now we're realizing that we should probably just treat them like any other immunologist patient and try to wake them up and mobilize them and get them going again. And then if they do develop that hyperinflammatory state, then at that point, we think of doubling down and doing more aggressive support. But then it's still just the basic principles of multi-organ support. And nothing that new or novel. I think antivirals like oseltamivir have not been shown to work. There's other antivirals that have not yet panned out in clinical trials. Hydroxychloroquine has some in vitro activity, but only very small clinical experience with that. So, and steroids is a big topic too. And I think maybe in that hyperinflammatory state, you could make an argument that steroids might be useful. But I think most people are just using steroids if there's another indication for steroid use, like bad PPE or stocks.
I think that's the other thing to remember is that, if they come in and they're initially COVID suspect, still all the other regular pathology happens. So we would treat that. So having said that, just as you would, community-acquired pneumonia for your COPD exacerbations, whatever other type of pneumonia they may have, those things still need to be treated. And they can get acquired infections as well, or super infections on top of their pneumonitis that they have. So you're exactly right with that. Do you guys have a set protocol as far as what you have for treatment-wise for your COVID-positive patients, Morad? Or not that I want to know what it is per se, but is there somebody that does that, or is it depends on who's around or who's on? Yeah. Is there an institution?
Totally, and in fact, it's really interesting. We had two committees that were struck like almost overnight. One was the therapeutics committee that started to review all of these studies that Amir was mentioning to see should we adopt them into our management, and mostly the answer is no to everything. And then we also developed a committee, which was kind of like a social media committee that looked at all of the information coming through different types of networks and emerging studies from the literature. And every day we get a report about what's new and what to consider, like a one-page report that comes at the end of the day from that committee. So that's a neat adaptation. So I feel like we're getting the latest information, but a lot of it doesn't, like you guys are saying, it doesn't really change practice that much. It doesn't shift the needle a huge amount. It still always comes back to the basics.
And we're really still early on in this, further than you guys are, I think, in BC, as far as the numbers in your hospital, and just the amount of the preparation. The stress is palpable. I mean, honestly, throughout most of the hospital, and really, that almost all boils around PPE and the potential of the lack thereof, and how to deal with these patients. And we're not even in the thick of it yet.
Yeah.
And so I think that's, to try to keep this communication going and to keep the morale as strong as possible is really challenging.
Yeah, there's no doubt, Neil. I think that's true of the whole country and probably the whole world right now. There's no doubt. Let me ask you guys one more question, which is that, we have a fair number of community surgery partners and listeners. So what would you recommend, either formally or informally, if there is formal agreements or transfer thoughts in your regions, if outside of a true emergent surgery that needs to happen, what would you recommend that the general surgeon in wherever, Timmins or Medicine Hat or I don't know, Williams Lake do, if they encounter in particular some of these patients?
I think it depends on the patient's physiology. If they need the emergent operation, they need the emergent operation, and to treat them as COVID positive. I think each institution, no matter how big or small, has been preparing for this, and so hopefully within the OR there is some sort of standard operating procedure or something that's set up to have a dedicated OR, the team to be able to go through things. I still think, and again, this may be a bit controversial, but I think that certainly if we can test, which again has been a big issue, but if we can test perioperatively, then, and we can find out that they're negative, again, knowing the false negative rates and everything there, but if they screen negative, are negative, then that, if anything, that takes down the stress level of people, and I think is super important. We shouldn't treat them any differently, treat them the same way, but that inherently takes the stress down somehow.
Yeah, I agree, and I think one thing, I'm sure it's this way in the rest of Canada too, but we have different layers of emergency operations command. Like we have hospital level, regional level, and provincial, and they all coordinate in multiple meetings a day. And in our surgical response to our COVID positive and just emergency surgical conditions could follow a similar type of organization network. And like in BC, I mentioned to you guys, we have a new web-based platform for interaction between surgeons. It's kind of like a Twitter feed. And so that group has really started, that platform has started to really become active as people start to trade ideas. And we're hoping to use that platform to even coordinate surgical care between sites, but recognizing that some of the COVID hospitals will get overwhelmed and may not be able to do urgent surgery. So that might be a pathway to distribute the work a bit better.
Is your platform, is that Reticulum that you're talking about?
Yeah.
That is super neat. Even before COVID, I think that was a really neat platform, and I think that the discussions on Reticulum have been really super high level and super useful. Sort of related to this sort of redeployment, managing resources, has there been any discussion at all about redeploying, let's say, residents, for example, or surgeons into ICUs, or kind of becoming, undifferentiated physicians to kind of help should that need arise? I don't think we're there yet, but has there been any discussion about that?
So within our department, we've had that in the Department of Surgery. We felt that we should try to redeploy amongst the division or within the department first. So there are divisions that are bigger than others, and some of the smaller divisions. In our group, would say it'd be like vascular surgery, thoracic surgery. If one or two people get quarantined, that's a big problem. And so we felt that we would try to deploy within the department first, and then, of course, to be more of an undifferentiated physician, as it were, to help out in other areas. I don't think we're yet there to say that surgeons have to become intensivists, and there's a fear that may become. Those people that have some background within it, of course, are going to get ramped up. The way our system is, certainly the anesthesiologists are much more comfortable with the ventilator than anybody else, apart from the ICU and some emerged groups. So that's what we've decided to do thus far.
Yeah, we did the same thing. We worked really closely with our residency program. Our residents brought all our residents back to some of the big hospitals, and the residents came up with a very innovative call schedule that actually makes sure that some of them are rested and off, and then we cycle in every week. We refresh the workforce, and so that also gives us room to support the ICU. So some of our residents have been seconded to the ICU, and some of the surgeons have asked about how to support the ICU, and there are online resources for that, which we can give you the link to if anybody wanted a quick crash course in how to support ICU. If this pandemic really does escalate as it's projected to.
And we have, from a resident point of view, have pulled residents back away from community rotations back home, as it were. But we've not pulled our general surgery residents off their other services yet, or anything like that.
Yeah, the blocks have disappeared now, and everybody's just on the standard general surgery services.
That's fantastic, guys. Any other comments before we wrap this up?
I just had a question about negative pressure ORs, because it still comes up a lot. We've sort of put that behind us. Of course, there's data suggesting that we still shouldn't. I don't know, but what do you use at your hospital, Morad and Chad, for the COVID positive patient?
We have 2 negative pressure ORs, I think, and we're trying to make those the COVID positive rooms. And then this is also relevant in the emergency department. We tried to do some resuscitations in the 2 negative pressure rooms in the emergency department. It was technically very difficult to do, so actually we're converting our trauma base to negative pressure at the moment.
Yeah, our experience was very similar. We tried to, this past week, do a gunshot and a stab in the isolation rooms, and it was not physically possible to do that. The patients did fine, but it was challenging. So we've converted one of our 4 trauma bays similarly. We've certainly operated on a number of suspected COVID patients on the emergency side of things over the past 10 days, and we have not been in our negative pressure rooms at all. So that debate does continue locally in Calgary.
So you do have negative pressure ORs, though?
It is possible, yeah.
Okay. Yeah, we don't. And I think most, at least when I talk to most of the groups across Ontario, we don't really have negative pressure ORs per se. They're relatively negative in that the core is slightly higher pressure than the OR itself, but all the ORs within the OR is positive pressure, as we mentioned earlier. Interesting.
Well, to your point, Neil, and you described it quite well. I think that's really the message that's been going across the country in most ORs and most systems, is that the positive pressure that you run with the circular air, scrubbing of the air in and out over the course of the hour should be okay. And I think that's probably true, although there's certainly some strong opinions otherwise.
Yeah.
Yeah, Chad, I don't know where this would go in, but in going back to just a note about the resuscitation of patients, I think it's important to remember that not to over-fluid resuscitate them. I think many of us are going to be involved with resuscitation of these patients in different contexts. And and what we know is about this this COVID-19 is that they don't need a lot of fluid, and if they develop a secondary sepsis, as Neil talked about, you can judiciously fluid resuscitate them. But the idea would be always to do so very judiciously, use ultrasound guidance to assess volume size, and just try to keep them on the dry side, even if it means giving them a bit of pressure. The idea is to try not to exacerbate the viral pneumonitis gas exchange issues by also creating pulmonary edema. And some of the patients get this myocarditis, which could predispose them to CHF, and which would make them even more fluid intolerant.
Yeah, I think that's a great point, Morad. I mean, the other corollary issue is who to intubate and who not to, and when to do that. And I think we've certainly seen a bunch of over-intubations and a bunch of wet patients up front. And so not to blame any particular subspecialty, but just to point out that our critical care colleagues and many of our general surgeons that have critical care training should probably be involved in a collegial way a lot earlier, or certainly very early, to help make those decisions, so no particular frontline physician or nurse or anybody feels like they're out on an island, not sure as to what to do. I think we're all available and ready to help.
Yeah, like we are so worried about these patients because some of them present with silent hypoxemia, so they look okay, but they're stats from the 80s.
That's a really good point.
And then you put oxygen on them and they don't come up right away. And then they also have been known to sort of deteriorate quickly. So, and then if you have to crash intubate somebody who's on airborne precautions, it becomes a technical issue. So I think people were really focused on early intubation of these patients to try to avoid that quick drop-off in oxygen saturation, to avoid oxygen debt, and also to avoid uncontrolled intubation. And I think that in principle, it is good to think about early intubation, but I think we're moving towards a more nuanced approach, which is that if you can sustain them with high flow nasal cannula and continuous oxygen saturation monitoring, you might be able to get some of these patients through without intubating them and creating all the downstream iatrogenic problems that Chad, you mentioned, fluid overload, barotrauma, et cetera.
Well, where are you? I think it's hard to fit everything on a podcast about what you might want to know in terms of a ventilator. I'm just going on a limb here, but where would you guys recommend going for resources and staying up to date for, let's say, the community surgeon who may theoretically be called upon to at least sit and watch a ventilator, if not be actively managing COVID-19 patients in the ICU?
I think when we start to double and triple our ICU capacity, and start putting ventilated patients on the wards, it is possible that non-intensivists and non-anesthesiologists will have to run these teams, and it's happening in Italy, and even in Australia. I heard that surgeons are volunteering to help, and so I think general surgeons and surgeons in general would be great at this. I think most of the patients will probably be on high flow nasal cannula. Some may be on invasive mechanical ventilation, and there are some online resources to that. I just was noticing this morning that the SECM has a crash course, a primer in critical care for non-intensive care physicians, and so Chad, you said we could provide a link to that.
Yeah, you bet. Amir has kindly puts up resources as the show notes for all the listeners in the podcast links, and so he'll do that again for all of you.
Yeah, I agree with Morad. There are some great podcasts that break it down and make it very easy. Human resources will be taxed. A person who's not too familiar or comfortable with the vent's best human resource is the respiratory therapist. So even just hanging out with a respiratory therapist now, just to say, what's that button? What do I need to do? What's this? That's probably going to be worth your salt as well, just to do that now before the resources, both human and physical, get stretched.
And I think in a well-organized system, nobody will be really left. Like, I think the teams will have sort of a hierarchical structure where there's the intensivist and anesthesiologist and then there's surgeons, and they're all kind of working together, even though they're sort of distributed. So I think within our teams, there's so much depth and resilience that we'll be able to support each other. And again, that's another benefit of this crisis, is we're learning how to incorporate the expertise of other specialties into our work. So I think we all have a lot to bring to the table. If the pandemic expands further, I think we'll be able to benefit a lot from the wisdom of all of our colleagues.
That's fantastic. Guys, thank you very much for doing this. It's been a pleasure, and it's always amazing to see what Canadian surgeons of all different subspecialties can do in times of need. It's a great group to be part of.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.